Please raise your right hand. Do you swear or affirm that the testimony you're about to give will be the truth, the whole truth, and nothing but the truth?
Yes.
Thank you.
Good morning. Could you please introduce yourself?
Melinda Wiclak.
And Melinda, we just met a moment ago. I'm Will Edie. I represent the estate of Jennings Fleenor in a lawsuit against the nursing home where he fell and died a few days later, Riverview Nursing Home. Do you have any familiarity with this case at all?
No.
Other than being asked to show up today?
Right.
Okay. Have you had your deposition taken in like this before?
No.
So let me run through some ground rules. Number one, this is really just to find out what you know or don't know. So not knowing is fine. I'm going to ask questions. You give the answers the best you can. I very well may ask a bad question. I may use the wrong words. I'm not a therapist. I may be confusing in how I ask it. Just let me know if you don't understand anything. Okay. It's important that you give verbal answers because we have a court reporter writing down words, okay?
Okay.
It's important for the same reason that we don't talk over each other. Even though you might know exactly what I'm going to ask, if you can still wait till I finish because you can't write down two things at once.
Sure.
Okay. We are recording by video today, and this may be something that's shown to the jury at some point. I really want to make sure they can hear what you have to say. So please speak up, and I may do this or something occasionally, okay?
Got it.
Okay. It's fine if you don't remember the answer to a question or don't know the answer to a question. Just let us know, don't guess, okay?
Yes.
I think I said if you don't understand a question, let me know, but for seriously, you can just say, what are you talking about at any point, okay?
Okay.
Occasionally, the lawyer for the nursing home here may say the word objection, and that's so that we can go argue with the judge later when we're not wasting your time about whether I'm asking bad questions or not. You're still going to answer the question, okay?
Okay.
And it's just a little awkward interrupting at first, but just if it is happening, just wait and then answer the question. And if you need me to repeat it, I'm happy to do so.
Okay.
Oh, I should probably read my list of rules. You were just sworn in under oath. I'm going to represent to you this is the same oath you would take if you were swearing in front of a judge or giving testimony in front of a jury. Are you comfortable with
Yes.
that? Okay. Is there anything that would prevent you from giving accurate and complete testimony today?
No.
Great. Can you explain your job title, or profession for us? What do you do?
I'm an occupational therapist.
Okay. And I know you were one of the occupational therapists who provided therapy to Jennings Fleenor at Riverview. Is that correct?
Correct.
Do you work for Riverview?
Not anymore.
Okay. Who do you work for?
Progressive therapy.
Okay. I've heard what was the name I thought? Concept?
That was who I worked for while at Riverview.
Got it. So while you were at Riverview, you worked for Concept Therapy?
Concept Rehab.
Concept Rehab. And at some point you've left and gone to Progressive Therapy?
Correct.
Do you no longer serve patients at Riverview?
I do not.
Okay. When did you go from Concept Rehab to Progressive Therapy?
I believe it was September of 2016, maybe.
Okay. So in this case, well, let me see.
I might have, if you give me a moment to, in my mind.
Yeah. You can take time anytime you want. I'll pull my note on when you were doing therapy, which I thought I had here. So you did the last therapy note we have in August of 2016 for Jennings Fleenor at Riverview.
Okay.
Is it fair to assume that at that point you were still at Concept Rehab?
Yes.
Okay.
Yes.
Is Concept Rehab affiliated with Ottawa County or Riverview, to your knowledge?
Object to the form.
Let me ask you a better way.
Okay.
So it could be the fact that Concept is some separate company that does therapy at multiple places and is not affiliated in any way with Ottawa County or Riverview, or there could be some other relationship where they are somehow affiliated. I'm just trying to figure out.
I don't know the binding contract form of it. Concept Rehab is they employ therapists who Concept Rehab then contracts with other, like nursing homes,
Okay.
outpatient
Not
centers.
Not just.
Not just Riverview.
Okay. I'm talking over you. I'm sorry. I gotta stop doing that. She's already giving me a look. So when you were providing therapy through Concept Rehab, were you only doing that at Riverview, or were you at multiple facilities?
I was only at Riverview.
Is that true of all the therapy staff that were providing therapy at Riverview, that was their one location, or did some people go around to different places?
If you have so your day depends on how many patients you have. If you have a short day, you might go to other nursing homes that are contracted with Concept Rehab.
Okay.
I did not.
Okay. You're an occupational therapist?
Correct.
Can you explain for folks who have no experience with occupational therapy what that means?
It's a discipline that treats individuals with any type of deficit, injury, disability in order to regain the ability to participate in what we call your activities of daily living, whatever you do during the day. So in the nursing home per se, it would be like, can you shower? Can you get dressed? Take yourself to the bathroom, cook your meals.
Okay. So any of those, whatever a particular resident's deficits might be, occupational therapy would help with helping them do a better job or be more independent with that.
Yes.
And how is that different than physical therapy?
Physical therapy mainly works on lower extremity, so your legs, balance, walking, transfers, meaning getting from one surface to another surface.
Okay. Is there some overlap there?
Quite a bit.
Okay. So where is the overlap, or how would you explain that to folks?
Each therapist kind of has a specialty, and each building has a way of distinction.
Okay.
So you kind of, depending on what you're comfortable. A physical therapist would not necessarily work on dressing. That's what an occupational therapist would work on. But in the aspect of dressing, an occupational therapist would work on transfers, which is a physical therapist job.
Okay. So there might be areas in your occupational therapy work that would overlap with physical therapy, because of the nature of the activity.
Exactly.
Okay.
A lot of it depends on, unfortunately, insurance, how much they're going to pay. So you might have to just do one discipline.
Okay. So you might.
Makes sense.
Yeah. If I'm hearing you right, there might be times where you think it's to a resident's benefit to help them to accomplish an activity of daily living better that would overlap with physical therapy that you might get into because for whatever reason about payment, they're not able to get physical therapy.
Correct.
Okay.
Correct.
What's the goal of occupational therapy in a long-term care setting like Riverview?
To maximize functional independence in order to have a quality of life, independent quality of life.
Okay. We're going to look at some of the records specifically, but I see things like an evaluation, plan of care type phase, records of specific treatment sessions, and then a discharge. Is that reflective of the regular process that residents would go through?
Correct.
Can you explain kind of just an overview of what that process would normally entail? I know it's probably customized to residents, but in a broad sense.
Across the board with occupational therapy, we are not independent on our own. You have to have a physician's order for occupational therapy. So the doctor orders occupational therapy. You then have to have an evaluation, which basically the doctor's orders are most times specific on what they want occupational therapy for. So then you do an evaluation based on those orders, showing what their prior level of, it's called prior level of function, what their ability before the injury, onset, disability, what that was previously, what their current level is, what you are going to do to get them back to that prior level, how long it's going to take, and the goals. Then you begin treatment based on that plan of care, that evaluation and plan of care.
Who does the evaluation and plan of care?
That has to be done by a therapist,
And who can do the actual therapy sessions?
a therapist or an assistant.
Okay. In your work as an occupational therapist, and I'm going to restrict it to while you're at Riverview.
Okay.
Because I assume it could be different. But while you're at Riverview, as an occupational therapist, would you interact with or work with other types of care providers like nurses or aides at the facility?
Yes.
How often, I mean, can you give me a sense of what types of interactions you'd have with them regarding patients?
The nurses provide a lot of information, as do the aides, regarding the current level of a patient. Frequently, that's where the orders are originated from. If an aide, say you take someone to the bathroom and they're really struggling, the aide will say, 2 weeks ago they were much better. The nurse might say that. That's one example.
So when you say originate the order, how does that happen? I mean, obviously a doctor has to sign off
So
eventually.
then the aide or the aide would relay it to the nurse. The nurse would then call the doctor and say, this is what we're seeing, can we have an order for therapy?
Okay, so the doctor has to sign off on it, but the idea for it or the scope of it may come from the nursing staff.
Correct. Or the family.
No, anytime. Nursing homes, or let me back up. How long have you been an occupational therapist?
Since 1999.
And how long over the course of your career since you became a therapist in 1999, how much of your time has been spent helping rehab or long-term care residents in a nursing home setting?
2005,
Okay.
I started. And
What'd you do before that?
I worked at a special needs school
Okay. So 2005, I'm sorry I interrupted you. You started what?
at Riverview.
Okay.
Prior to that, from 99 to 2005, I would do like weekends at a nursing facility, but hit or miss.
Like as needed?
Yes.
Okay. Was that part-time or as needed stuff through Concept or was that separate?
No, it was separate.
So in 2005, you started Riverview. Is that full-time?
Yes.
Was that through Concept at the time?
Yes.
Why'd you end up going to progressive therapy?
More flexible schedule, basically.
Okay. No problems with Riverview, there wasn't?
Not with Riverview.
Okay. Over the course of your time from 2005 onward at Riverview, were you handling residents who might be in rehab short-term stays as well as long-term stays?
Yes.
While working at Riverview, did you expect and rely on nursing staff to provide the day-to-day care the resident required?
Yes.
So you weren't doing hands-on care outside of therapy?
No, part of therapy, part of occupational therapy, we might have done like their morning care. The therapist doesn't do it. We, I guess, watch the patient do it as part of our therapy. We assist the patient to do it. So there are times that the therapist does do some of the care.
Okay, so if you're working with a resident on independence brushing teeth,
Exactly.
that might be their morning brushing
Exactly.
teeth. Okay. Would there be aides or nurses as part of that, or being trained in part of that?
Yes.
What are the circumstances where the nurses or aides would be involved?
For the example of brushing your teeth, we would have the aide come in and give them tips, techniques, strategies, show them the specifics that we want the patient to do, so that the aide then carries that over
Okay.
during the rest of their session, their day. Their
On a
time with,
day-to-day basis?
yes,
Yeah.
yes,
Okay, so you're not helping everyone in the facility brush their teeth, but if you train a particular resident and maybe their staff, the nursing staff, to help them do a better job after they leave therapy?
Correct.
Okay. Do you expect and rely on nursing staff or when you were at Riverview, to have the adequate staff to provide the care and services to the residents?
Objection. In answer.
Can you repeat it though?
Sure. Did you expect and rely on the nursing staff at Riverview did you expect and rely on Riverview to have sufficient nursing staff to provide adequate care?
Yes,
Did you expect and rely on the nursing staff to provide the day-to-day supervision required to ensure residents are safe?
yes,
When you were at Riverview, did you have access to resident medical records who were in the therapy program?
yes,
So some of what I see in your evaluations includes like prior medical history and things like that. Is that where you got that information?
Correct.
Okay. Did you rely on those records to be accurate?
yes,
Is that a normal, reasonable part of being in occupational therapy, is to consult with other providers' records?
yes,
Do you agree accurate documenting of medical care in the records is important?
yes,
Is it important to resident safety?
yes,
Do you rely on the accuracy of those records to be sure that you have an accurate understanding of a resident's condition?
yes,
Is it important for your records of the care or therapy you provide to be accurate?
of my own records,
Uh-huh.
yes,
I assume you try to make them accurate?
I do,
Okay. Can we agree that residents at facilities like Riverview have the right to accurate records?
yes,
Do you have any independent memory of Jennings Fleenor?
I do.
Okay, tell me what you recall of Jennings.
He had a distinct southern accent. He had I might not be remembering exactly if at one point he was only a single amputation. I don't remember if later on it was a double. I can't remember.
It was, but we'll
okay.
let you look at the records.
I thought it was.
What else do you recall?
He used to cross his amputated leg
Okay.
and swing it like there was a leg there and talk about it, how it was cut off by the EMS in Virginia and left there. He told that story a lot.
Did you understand that to be a fictional story?
Yes.
Okay. Was he joking around? Was
No,
he
in his
confused?
mind that
Okay.
was, and I don't know if there was, I never asked if there was an incident that occurred that made him think that, but that was a story he told a lot.
Okay. What else do you remember about Jennings Fleenor?
He liked racing,
Like car racing?
car racing. He was big into car racing, and we always ask him what their goals are for therapy. His goal was to race again.
It's good to have dreams. I could be wrong. It seemed like you like him.
I did like him.
Okay. there are some times with nursing care where he was a little difficult or ornery.
He was.
Okay. How did that play out in therapy? Was he cooperative? Was he difficult? How would you describe it?
He was confused. I don't want to put other people's, I think his confusion could be seen as being uncooperative.
How so?
A lot of times patients with confusion, dementia, Alzheimer's, just in general confusion, have a difficult time following requests given to them. And when they don't follow the requests, it can be seen as being uncooperative, being difficult. I enjoy dementia patients, so to me it does not seem uncooperative. It didn't bother me, but I think it did some.
Okay. Did you see that as, part of his condition that you were there to help through?
Yes.
Okay. Were you able to do that to the best of your recollection?
I felt like I was, yes.
Okay. Do you have any interactions with Jennings Fleenor's family?
I do not remember any of his family.
Okay. Do you agree that it was reasonable for Jennings' family to expect he'd receive good care at Riverview Nursing Home?
Yes.
Do you have any, I'm not suggesting you should, but this is my chance to talk with you before trial, so it's like our one chance to kind of
Okay.
figure everything out. Do you have any criticism of Jennings? So let me back up. Jennings fell on December 29th, 2016. It's July 29th, thank you. July 29th, 2016, when his shower chair tipped over in the shower.
Okay.
Do you have any direct knowledge of the circumstances of that?
I cannot remember that.
Okay. So as you're sitting here, you don't?
I don't remember that particular incident, or in my mind, I believe I remember a discussion about it, but I don't know if it was at the time or later on.
Okay. I'm going to show you some stuff later. We'll talk more
Okay.
about it. But did you weren't like, no one kind of ran to you and said, hey, he's fallen in the shower, and you went there or anything like that?
Not that I remember.
Okay. Do you have any criticism of Jennings or his family in any way related to causing or contributing to his fall?
No.
What did you do to prepare for the deposition today?
Nothing.
That's fine. Are you represented by the nursing home's lawyer today or no?
No.
Okay.
I don't believe that's how
No,
it
you're
works.
not.
Okay. Have you had any, and I'm talking like recently about this lawsuit, not in the past conversations. Have you had conversations with anyone about Jennings, Fleenor to either prepare for the deposition or once there was a lawsuit filed or anything like that?
Not about him.
Okay. So I'm a nosy lawyer. Now I want to ask you what it was about. If there was something, you had conversations about the lawsuit or anything like that.
I did have a call that said, this is what a deposition is.
Okay. Who was on that call?
2 other therapists and I don't know the title, the operations manager for Concept.
Okay.
I believe it's the owner. I
Okay.
don't know her title anymore.
I think you've already said this, but just so I make sure I'm right. Was there any discussion about specifically Jennings Fleenor?
No.
Okay.
No.
So this was more like, hey, here's what to expect.
Yes,
They tell you
this
I'd
is
be
what
really
a
nice.
deposition is.
I tell you, it'd be great and enjoyable.
Right. We did not, There was no specifics about him.
Okay. Were any of the other folks on the call therapists who had provided care to Jennings?
Yes,
So who were the folks on the call?
Michelle Miller and Lois. I'm not sure how to say her last. I don't remember her last name. But
Okay. Carl?
yes,
And did you guys end up talking about Jennings specifically at
No.
any point? Okay. Did you review any of your records to prepare?
I have not seen my records.
Yeah, you might not even have access to them.
No, I do
Okay,
not.
That makes sense. So this is gonna be kind of a random one. But we got some emails, and I just don't know who these people are, so I'm just gonna ask you, because it's vaguely therapy related. This is, I'm handing you, on my slide, exhibit 13. Take a second and look at it. So one of my questions is, I see this therapy at co.ottawa.oh.us.
Correct.
Do you know what that is?
That is the therapy email. It was the
Okay.
I don't know if it still is. It was the therapy email when I worked there.
So when you say, oh, what did I mark? Did I mark that 13 or 12?
You did 13.
Okay. So when you say the therapy email, is that email that the concept rehab folks would have access to, or just,
Yes.
Okay.
Yes.
so is there any way to tell who is therapy in this email chain?
Unfortunately, no.
Okay. I know there is some therapy around June, and I'll figure out if it's you or not, but would your expectation be if someone is from the therapy, concept rehab therapy folks, is emailing about ordering specific equipment for a specific resident, that it would relate to therapy that's going on
Correct.
with them? Okay.
Correct.
Who's William Clymer? If I'm saying that right.
When I was employed there, he was the director of purchasing.
Okay, so literally the guy you'd say, hey, can you order this
Correct.
thing?
Correct.
Okay. Great, thanks. I'll take that out of your way. Okay. Now we can start looking at your notes. And you exhibit 14, and I'll present to you, this is a packet, therapy records we got from the facility. So if they're not in the right order or whatever, forgive us. And I believe all of these relate to therapy that started in December of 2015. Does that look right?
Yes.
So in this case, you were the therapist who did the initial assessment that's on the first 2 pages of Exhibit 14.
Correct.
Now, I see most of the therapist notes. I know there's a couple assistants, Jennifer Jensen, Wilma Robleski, but most of the therapist involvement is Michelle Miller, who also does the discharge. So I can save a fair amount of these for her, but my question is that kind of normal? Is there any reason that would be the case that you would handle the initial assessment, but Michelle would kind of take over the therapy role?
It varies depending on your caseload, on if I was on vacation for the day. She's also a therapist, so I'm a therapist, she's a therapist. It depends on who's available.
Okay. Let me ask you this. In the other ones, and I could be just making this up, but it seemed like the person who did the plan of care would be the one primarily on the therapy and do the discharge. Is that the more traditional way? Like you would have this patient for
In a
this-
perfect world, you would
Okay.
keep the same patient.
So it could be on this, he came in for the eval on a day, Michelle wasn't available, but she would be the one handling it?
Correct.
Okay.
It could have been, I mean, I'm not saying that I saw him on the weekend, which a lot of times if you have someone come in, he didn't come in, but you have an order on the weekend, whoever's covering for the weekend does the eval, and then the other therapist is following.
Got it, okay, that's helpful. So in this case, the only thing that you really did was the plan of care here in the first couple pages.
Correct.
This is after, if you look on the first page, medical diagnosis 1, this would be after the second leg amputation, is that right?
I can't,
I'll represent to you, this was the second one.
okay.
I don't
The
mind
medical
this.
diagnosis, therapists can't make that up. I can't as a therapist pick a medical diagnosis. So you have to, whatever the doctor lists as the medical, that goes in.
Okay.
That's not something that.
You have control over.
Yes.
Okay, and if we go down to reason for referral, is that a section where you would be able to put in what?
Correct.
And what did you write there?
Patient returned to this SNF after acute stay for right above knee amputation.
Am I right that the left leg, was it below knee and the right leg was above knee? Or do you recall?
I do know that one was below knee. I don't recall.
Okay, so you would be saying here, this is a right above knee amputation.
That's what I have indicated.
Okay. What was the purpose of this therapy?
Under my therapy necessity, necessary for return to MIN, which means minimal assist, simple grooming without therapy patient at risk for increased assist from staff.
Okay. So essentially, he's in the hospital. He has a right above the knee amputation, and at least on the occupational side, your goal is to help him get back to his prior functional level
Correct.
with grooming specifically.
Correct.
Any reason why that was grooming in this case? I don't know. I'm just.
I don't have it. I would have to read through. I believe at the time that was pretty much the only thing he was doing on his own.
Okay. So it has more to do with what he would be capable or doing already that you're focused on.
Right.
Not like grooming because of the amputation specifically.
No.
Okay.
No.
You list precautions, fall risk, confusion.
Correct.
Where do you get that information during this type of assessment? How do you figure that out?
During the interaction with him, just how his demeanor is during the eval.
And then you indicate, can you explain a little bit this initial assessment functional deficits section? Can you explain what you're doing there, what you're evaluating on that block?
So cognition, these are like drop down boxes. You just pick which ones you're going to be observing, assessing. Cognition, I would do orientation, his ability to follow commands, his recall, safety judgment, just as a baseline and a current level and a prior level in order to be able to do his own care.
So at this point, am I right in understanding that, at least in the current, so as you're seeing him there that day for your assessment, he's somebody who's alert to himself, at least he knows who he is.
Correct.
He's somebody who is moderately able to, has moderate cognition in the sense that 51 to 70% ability to follow commands and recall and safety judgment, but requires frequent direction from you depending on the situation.
Correct.
Is that consistent with your memory of him?
Yes.
At the as it relates to his self-care with grooming and hygiene, he starts off, as you were evaluating him, I should say, at the time, he needs maximum assist.
Correct.
Can you explain for folks who aren't therapists what that means?
Max assist is another person is providing 76 to 99% of the task, care, follow through.
Okay, so upper body dressing, someone else is doing the majority of helping him get the upper body dressed.
Yes.
Same thing with grooming and hygiene, someone's doing most of it for him.
Yes.
And your goal was, or I guess it sounds like it's always to try to get back to the prior level of function?
If at all possible.
Okay, and obviously that's not always possible, I assume.
Correct.
One of your short-term goals, it relates to upright sitting and maintaining proper positioning. Is that right?
Yes.
How, and if you recall independently, or if you just know based on this, someone in this kind of condition, how does having both legs amputated affect someone's ability to keep themselves positioned upright in a safe way?
You no longer have your center of gravity, your balance. Your legs are used to support yourself on the floor, so without those you have to obtain a new center of gravity in order to maintain sitting.
Is it going to require him to use his arms a lot more to try to replace his leg balance?
Not necessarily in the aspect of just sitting still, but in the aspect of then doing anything, yes.
Okay, and I've seen references to sitting balance where it says static balance, and sometimes it says dynamic. Can you explain the difference?
Static is sitting still, not moving. Dynamic would be sitting and having to reach out of your base of support.
Would dynamic balance also include if you're sitting but the chair you're sitting on is moving?
In a way, in a wheelchair, just for somebody to push you, only the initial force.
Okay, so when you go from still to moving.
Yes, but very minimal. It's
Okay.
still pretty much static balance.
Okay.
It would have to be someone like in a roller coaster, to
Okay.
catch yourself. Otherwise, it's not a big factor.
And when you say, center of gravity and balance, how does that affect somebody when they lose their legs in terms of their ability to not tip over?
You have to find a new center of gravity, so it would be more in your trunk and chest area. It takes a big learning curve, I would imagine. I've never had it, but a lot of upper body and trunk work to regain a center of gravity.
Okay. Is that something for, older people in a long-term care setting with cognitive limitations that they might not ever accomplish?
Yes.
Objection.
Do you have any specific recollection of this evaluation in December?
I don't.
Okay. I think I saw that you had, and this sounds like what you were testifying to earlier, you had dealt with Jennings Fleenor before he had this amputation.
Multiple times.
Okay. Did you notice, I mean, obviously, is the prior level under functional deficits and ADLs, is that what you're kind of pulling from your prior experiences or prior records of experiences with him?
Yes.
Okay. So one difference you saw was in his ability to assist himself. Is that fair?
Yes.
Do you remember a difference in his cognitive level? I mean, I know statistically it looks in the same range, but within that range, do you recall a change?
From the initial time that the very first time I worked with him to when I left there, I do know that he had a significant decline in his cognitive abilities.
Okay. Do you recall from prior to this surgery, this amputation, to seeing him just a few days later, a decline in that?
I don't.
Okay. And I have to say, because I asked a bad question, do you recall that there wasn't one, or do you not recall whether there was?
I do not recall.
Is there anything else that you think is important about this evaluation for us to know about?
Objection.
Not necessarily.
Okay, and I'm just asking because you know the form better than I do.
Right.
What did I mark? 14?
Yes.
Okay. I'm gonna give you 15. Praise you for that one. Thank you.
Thanks.
And I'll tell you up front, we don't have to spend a lot of time on this one because I don't think this is you either, for the most part. But I just had a couple questions from the initial evaluation. Go ahead, you can take a look.
No, I was just, okay, yes.
I don't think you did the discharge either, but let's double check. No. So I'll only ask you a little bit.
Okay.
With the initial assessment, at this point, there's this balanced dynamic sitting. That's the sitting while reaching or outside your, normal still position. Is that right?
Correct.
And there's balanced static sitting, which is when there's no, you're sitting in your normal position, not moving around.
Correct.
Can you explain what fair means when it relates to balance?
With dynamic balance, a score of fair is you have difficulty crossing midline.
What does that mean?
Midline's like this, so if you wanted to reach over to get something,
Okay.
minimal weight shift. So you're not like moving a big.
Okay. So you have, if you're not reaching across center line, if you're not doing a large motion, you have decent balance, but you're going to have a problem if you do try those things.
Yes.
Okay. You might require assistance from staff to not fall over.
Correct.
Okay. And then poor plus, am I reading that right?
Yes.
Can you explain what that means?
For dynamic, able to sit supported, which means like the back of a chair, you're up against something. Minimal assist means that you're doing all but 25% of the work to reach side to side.
Okay. So if
But
you reach side to
you can't
side,
shift weight, so you're not shifting your weight, you're reaching,
so you can stick your arm out but not lean?
pretty much, yes.
Okay, and is it fair to say if you need minimal assist, that means somebody has to help with the reach process to keep you from falling?
Correct.
Okay. Great, I'll take it out of here. Thank you. Maybe I did these out of date or it's gonna bug me for the rest of this case, but that's okay. I'm handing you exhibit 16. Do you recognize exhibit 16 as the plan of care and daily notes and discharge for Jennings Fleenor's occupational therapy that was started in March of 2015?
Yes.
Okay. So what was the basis for starting this? Sorry, you know what? Hold on a second. You know what? Let's go off for 1 second. All right, we're back on. We figured out that it looks like there's a rogue plan of care on the front of what was marked as Exhibit 16. So we've removed the first 2 pages and remarked Exhibit 16 as a packet starting with Bates page Riverview NH 2457 through 2463.
I'm gonna hand that back to the witness.
So that is Exhibit 16. Do you recall this? I know we don't have your plan of care, so I apologize for that. Do you recall the purpose behind this therapy in March of 2016? And it should have your discharge as well. I don't know if the discharge summary helps.
It appears, reading the discharge, that it was for wheelchair propelling.
Okay. At the end of the day, was Jennings Fleenor able to get back to being able to propel himself in the wheelchair?
He was not.
Okay. So as of March of 2016, or I guess you discharged him April 1st, it was the Riverview that needed to propel and move Jennings around in a wheelchair.
Yes.
And it looks like, if I'm right, you discharged him because there wasn't improvement through the first part of the therapy?
Correct.
Okay, so part of your role as a therapist is if a resident is not improving, not just maintaining, but actually improving their status, you can't continue with them in therapy.
Correct.
Is that a billing thing?
Correct.
Okay.
It's a Medicare guideline.
Okay, so it's not the case that you don't think there would have been any benefit to Jennings from being in the program, it's that he wasn't showing an improvement in his functional level.
Correct.
At this point, Jennings is still at fall risk with confusion, correct?
Yes.
Okay. Made you, is it 17 or is it 16 out of your way?
Fingers crossed that I have the right clinic here on that one.
To recognize Exhibit 17, which starts, dates page 2478, as the plan of care and therapy notes for occupational therapy of Jennings Fleenor in August of 2016.
Yes.
Why was, or how was Jennings referred to therapy in August of 2016?
There was an OT screen, which periodically throughout the year, you just ask about the residents at the facility to see how they're doing. So while doing an OT screen, the staff requested occupational therapy for wheelchair positioning. They were concerned that he would slide out of his wheelchair.
Okay, and the staff there is the nursing staff at Riverview?
Correct. It could be nursing staff. It doesn't indicate what staff, but it could be anyone employed with, it could have been, not this specific instance, but a dietary staff member could say, during lunch, I noticed an issue.
So if someone needs help training how to feed themselves, that's something that could,
Could have been the housekeeper walked by and said, I saw they were spilling food a lot.
okay.
Could have come from anyone employed.
So in this case, dealing with wheelchair positioning, it's more likely but not certain that it's nursing staff. Is that fair?
That's fair.
Okay. I'm going to hand you Exhibit 12. Keep that one, but I just want to show you the page and the orders at Riverview that I think relates to this. And if you see there at the top, 8/2/2016 at 1443. The order summary is OT to eval and treat per order, and beneath that, a few minutes after that is entered wheelchair management to be added to OT plan of care. Do you see that?
Yes.
Does this give you any indication of how this might have originated?
No.
Okay.
After the therapist does the evaluation, they have to put an order in, that the order then goes to the doctor to sign.
So that's what we see here.
So I wrote OT to eval, I wrote the OT eval, I wrote that.
Okay, can you read that? The part you wrote?
OT to eval and treat, OT eval completed per order, recommend continue occupational therapy treatment 5 times a week for 30 days for therapeutic exercise and activity, 80-hour training, neuromuscular re-ed, patient caregiver education, ultrasound, E-stem, and shortwave diathermy.
Okay.
That order was noted by the nurse. That would have been the nurse, Nancy.
And how would Nancy have gotten that from you? Or would she?
I believe at this time it had gone to electronic, so I type it into an order section of the patient's chart. Then the nurse, I don't know what they really do. The nurse sends the orders to the doctor, and then I must have I signed it, so I forgot to add wheelchair management in that list of things. So I would have entered a second one that says wheelchair management to be added to OT plan of care.
Okay, so someone, maybe nursing staff, based on it being wheelchair management, maybe not, but someone at the facility says, hey, would you guys, therapy, take a look at him, there's something going on.
Correct.
And then you took a look, did your evaluation, wrote these orders that then are memorialized and communicated to the doctor by the nursing staff.
Right.
Okay.
Therapy,
Go ahead.
I can't, occupational, you can't get paid for your therapy unless the doctor signs what you want to do. So that's what these are, him saying, yes, go ahead.
Got it. So back to Exhibit 16. Do you recall what the concern was with the staff?
Did you mean 17?
Oh, did I? Yeah, I did. I don't know why I have 16 there. Thanks. Exhibit 17. Do you recall the reason for the evaluation?
I don't recall the exact concern that was brought up.
I'll take 12 out of 1. Thank you. So, do you recall who brought it to your attention?
I do not.
Do you recall who brought him to the therapy department?
I do not.
If you were going to review a resident and you see that there was an OT screen in the past, and you wanted to see who had done all that, would you be able to look in the progress notes for the resident to see what the nursing staff documented about?
You can't, the OT screen is not part of a medical record. I don't believe it's basically just I don't know, a good to-do list, things to think, but then with the OT screen, we would look in the nurse's notes. So anything, an OT screen's basically like a piece, you take a piece of paper and you just jot down ideas and things, thoughts.
Okay, when you're doing that?
Yes.
Okay.
The information I would get from the OT screen, or put on the OT screen, I find in the nurse's notes.
Okay. So at this point, someone on the nursing home staff requests occupational therapy intervention for wheelchair positioning because they're concerned the patient, or you document, they express to you concern that Jennings is going to slide out of his wheelchair.
Yes.
And that's a change from his prior status condition.
Yes.
It apparently was concerning enough to somebody that they asked you to get involved.
Correct.
Okay.
It's a concern.
And you indicate that there's therapies necessary to help him with positioning, because without therapy, he's at risk for falls from the wheelchair and increased, well, actually, can you tell me what the rest of that means?
Increased active patient posterior thrust and risk for slide out of current wheelchair.
What does that mean, posterior thrust?
Posterior means to the back. So pushing himself backwards.
Okay. And can that be part of the fact that he doesn't have these lower
Yes.
legs? Okay. And for folks who are caring for someone without lower legs, they have to be aware that because of that change in the center of balance, they might tip back with them. Is that fair?
Yes.
Under functional deficit, can you read your note there in the middle of the page here? The narrative note there?
Patient utilizes tilt and space wheelchair, no headrest with staff repositioning. Increased trunk thrusting posteriorly with forward slide and wheelchair. Patient double amputation with poor stability, with wheelchair posture and ability to maintain upright sit.
Okay, so when you do this evaluation, based on what you write about how this came to you and your initial assessment, at any point, let me back up a second. If you had been told that this patient a few days earlier had tipped out of the shower chair and had a fall, would you have included that as part of the pertinent background in your documentation?
Objection.
Yes.
Okay. No question in your mind, if you had been told that, it would show up here?
Yes.
So based on the fact that it's not here, is it fair to conclude whatever staff from Riverview brought him for this eval at that time, the day you did the eval, did not communicate to you he had had a fall? A recent fall anyways.
That's what I would. Yes.
Okay. Is that information you would have wanted to know?
Yes.
Why?
It would affect how you proceed. I would have wanted to know what the circumstances surrounding the fall were. Is it something that I need to focus the intervention on? Is there some sort of emergent safety device needed?
Okay. Based on your recollection and your notes that we've reviewed today, let me ask you this question.
Can I look at one more spot?
Feel free to look.
Okay.
Okay. Based on your recollection and work with Jennings Fleenor and your notes that you've reviewed today, I want to ask you a few questions about Jennings' physical abilities.
Okay.
Is it fair to say Jennings isn't someone who has the core strength and balance to keep himself safely positioned in an upright state without some type of assistance?
That would be correct towards this time, with this time frame.
Okay. That was true back in your June, actually we looked at June, that wasn't yours, but if Michelle, no, wait, was that you in June? If Michelle Miller's work in June was correct, that would have been true then too?
Yes.
Okay. And is it fair to say that for somebody like Jennings Fleenor, had he been moved violently, moved quickly in a chair, even had the whole chair tip over, he wasn't someone who had the core strength and the balance to control himself during that fall?
Objection. You can answer.
Yes.
Okay. So if you had found out that Jennings Fleenor had tipped out of a chair backwards, I mean the whole chair fell backwards, are you picturing that right? Like the chair's moving backwards, someone stopped the back and the whole back tilted back. Does that make sense?
Can I ask what kind of chair?
Sure, shower chair.
Okay.
Are you familiar with the shower chairs that were in
Yes.
use? Okay.
Yes.
So if Jennings was sitting in that chair and the whole chair tipped backwards, Jennings Fleenor did not have the core strength and the ability to prevent himself from falling backwards, number one. Is that fair?
Yes.
And he wouldn't have had the strength and ability to control his body to prevent him from hitting the ground.
Objection.
Yes.
Okay, so if someone had told you that he fell like that, would you fairly be able to conclude that someone needs to be concerned about him having hit his head, the back of his head, when the chair hit the ground?
Objection.
Yes.
Okay. No one told you that the day you were doing this assessment, right?
Not that I indicated on the assessment.
And you would have.
I believe I would have.
Okay. Do you have any doubt that you would have noted if someone told you this guy just fell a few days ago that you wouldn't have written that down?
I cannot imagine that I would not have written that down.
You, on the second page of your assessment, you believed that there was a good opportunity for rehab potential. Do you see that? Mm-hmm. Yes?
Yes.
And the reason is because of your past therapy experiences with him.
Right.
Okay. On the next day, so if you can flip to page 2480, which is the third sheet here. You enter a note where you try to, because you have, where you're actually trying to perform therapy with him, correct? You may have to flip the page to the rest of the note, but you're actually attempting therapy with him on the next day, right?
Oh, I found it. I'm sorry.
That's okay. Your eval was on the second, right?
Right.
And on the third, you're trying therapy with him.
Correct. Correct.
If you can turn to your note, and I'm sorry, it's actually page 2481. Can you read your note that you put in on E3 that starts modifications?
Modifications to wheelchair headrest with new rest constructed and mounted for appropriate fit. Patient with poor alertness with nursing staff stating patient fell over weekend.
So, number one, do you recall modifications to the wheelchair headrest or new rest construction?
To be honest, not this exact time.
That's fine. Can you explain what that would entail in a general sense?
There's brackets where the headrest can be raised and lowered depending on the height. You can push it forward or back to accommodate their head position. If they're leaning, you can do it laterally. So I cannot remember the modifications that I made at that time, but they would have just been to keep probably his head in a neutral position.
So that's a new issue for him, right?
I don't remember.
Okay. That's new, at least as it relates to the prior therapy notes we
Yes,
saw.
correct.
Okay. So unless there was some intervening therapy where OT was involved, this should be a new issue.
Objection.
I mean, there's not one, but I'm just saying there would be a different note of your involvement if this had happened.
I indicated in the beginning that there was no headrest. I don't know on the discharge of the other notes if there was a headrest.
Okay.
And it is missing if there was never a headrest. I don't remember, and I didn't note that in the notes. But
That's helpful. Let me ask it a better way then. As Jenny Sleenor was brought to you for evaluation on August 2nd, there was no headrest in use at that time.
Correct. I possibly could have gone to his room. It doesn't mean he came to the therapy room.
Okay.
There was no headrest at the time that I observed him for the eval.
Your understanding of why you were asked to do the evaluation is because he's having trouble staying upright in his wheelchair.
Right.
that's despite having a seatbelt, right?
I don't know if he had a seatbelt.
I'll represent to you the records and testimony as he had a seatbelt.
Okay,
At this point, you adjust or put a new headrest, you mount a headrest to help and fit it to help him keep his head up, right?
correct.
So he's having trouble keeping his head up at this point.
It would indicate that, yes.
And then you identify that he is not at his normal level of alertness.
I identify his alertness is poor.
And you're noting that because that's not what you'd expect from him.
Correct.
So that's a change in his condition that you thought was important to note.
Yes,
And you either ask or the nursing staff volunteers an explanation for that, correct?
correct.
Do you remember who you were talking with about that?
I do not.
Would you expect that if nursing staff is communicating with you about these types of things that they would be documenting in their own nursing notes?
Yes.
And what do they communicate to you as to the explanation as to why Jennings Fleenor is not alert?
He fell.
Do you recall any specifics they communicated about the nature of the fall?
I do not.
You end up indicating there's 2 skilled treatments given. That would be your initial evaluation and then this one, correct?
Correct.
And then he's discharged, correct?
Correct.
And you indicate under the long-term goals that he's discharged because he's died or expired, correct?
I do indicate that.
Do you remember how you learned that this patient had died?
I do not.
Do you remember any conversations where anyone explained, what happened?
I do not.
Did you believe when you communicated with the nursing staff that Jennings Fleenor was not, when you communicated with the nursing staff that Jennings Fleenor was not alert, that was information you were ensuring they knew so they could take some action about it?
I would say yes.
And your expectation would be that if the nursing staff is made aware that a patient is not at his normal level of alertness, that they would do whatever nursing staff ought to do in that situation.
Yes.
And that's not your area. You would rely on that staff to take care of
Correct.
from a nursing perspective.
Correct.
I'll represent to you he had a seatbelt. But you note on the beginning of your evaluation that he's also in a tilt-in-space wheelchair. Can you explain what a tilt-in-space wheelchair is?
It's a chair that, if
You can demonstrate it. That's just fine.
If this is the wheelchair you normally sit in, a tilt in space allows you to tilt the chair back, kind of like a lazy boy.
Okay. And still, staff can move the wheelchair around?
And still, the staff can propel the chair.
Okay. So I want you to assume that at this point, Jennings that they use a seatbelt with him in the wheelchair. Okay?
Okay.
And you noted here that he's in a wheelchair that actually tilts back. I assume that helps maintain their position in the chair.
Correct.
And despite that, the staff bring him to you because he's not even able to maintain his position or keep his head up in that wheelchair.
Correct.
Was it your belief when you documented this communication with the nursing staff on the following day that you had appropriately communicated that this should be a concern for the nursing staff?
Objection.
Can you say that again?
Sure. So I only see what you wrote down, obviously.
Right.
And I don't know your professional standards for documenting, but, so I'm really just asking, are you, when you're talking with this nursing staff and you, based on what you documented, do you believe you communicated to them that this is a concerning situation?
I believe yes.
Were you concerned?
I do not remember.
Do you believe, based on your note and what you wrote, that that reflects that you would have been concerned at the time?
Yes.
Okay. And it would have been your professional practice to ensure that that was communicated adequately to the nursing staff or
Right.
doctor or whoever you talk with?
Yes.
And you have no reason to believe you didn't do that?
Correct.
In fact, you documented a conversation with the nursing staff where you show you communicated with them about his poor alertness.
Yes.
Any recollection either of any of the people involved in asking for the screen, involved in the screen, or on the following day in terms of the facility staff?
No.
I know you don't know what department referred him, at least based on the assessment. You know it was nursing staff that you spoke with on the second day, correct?
Yes.
Is there anyone else you recall communicating with about Jennings Fleenor on that day?
I do not.
Is there anything else you think would be important for a jury to know in this case that I haven't thought to ask you about?
No.
Have you had an opportunity to answer questions fairly?
Yes.
Okay, great. That's all I have for you. The
Okay.
lawyer for the nursing home, you have questions as well.
I have just a few very simple questions. You've had a chance today to look at some therapy records and to also draw upon your own memory of Mr. Fleener. I'm going to represent to you that in late July, the incident that we've spoken about involving the shower chair occurred in a standard shower chair. Do you have any reason to think that he should not have been given showers in a standard shower chair in late July 2016?
No.
And you were asked questions earlier about the shower chair tipping over. I want you to assume, because there's been testimony to this effect, that an incident occurred in which the aide was attempting with her strength, when she saw the chair to begin to totter, to keep it from striking the floor with force. Would that make a difference in your evaluation and as to whether or not you would have wanted, deemed that information to be essential?
I'm not sure I understand what you're asking.
Yeah, that was a very poorly worded question. There's been some testimony in this case that the aide that was with Mr. Fleener, as the chair began to topple, was using her own strength to very gently let the chair end up in a position on the floor. You would agree, would you not, that that would indicate a lesser degree of force and might cause you to evaluate the situation differently?
Objective form and characterization.
Yes.
Now, there were some questions asked about the very last evaluation that you did in the very last couple days of Mr. Fleener's life, and a note that you made with respect to a lack of alertness. If you felt that that lack of alertness were indicative of a life-threatening situation, your notes would so indicate, would they not?
I don't. Professional. I think that's out of my scope of practice to indicate. level of, I don't know how to answer. That's out of my scope to say if it was, to what degree of life.
Let me phrase it differently.
Okay.
Your note very simply seems to indicate that he may not have been particularly alert, or not as alert as you had observed him in prior situations. You would agree that doesn't necessarily mean that he's experiencing some kind of major physical event. True?
Correct.
And it could be as simple, could it not, that for whatever reason he was tired, he was, not appreciating the fact that he's being evaluated, whatever. There could be multiple reasons why he may not appear as alert that day than you had previously found him to be.
Objective form.
Correct.
And so we would be leaping to extreme conclusions, would we not, if we were to assume from that note that he was experiencing some kind of event, such as a brain bleed, that might be leading to his death.
I wouldn't be able to tell from that note.
Okay, thank you.
Just a quick follow-up. If you had wanted to say that Jennings Fleenor seemed tired, would you have written tired?
Yes.
If you'd wanted to say that he didn't seem cooperative or into therapy, would you have written that?
I would have written uncooperative.
You wrote poor alertness to indicate that you were concerned about the level of alertness you were experiencing with him, correct?
Correct.
And you expected the nursing staff to take medical steps, if appropriate, to deal with that?
Correct.
Because that's outside your area.
That's outside of my area.
Okay, that's all I have.
And you would rely upon medical staff to determine whether a deficiency in alertness required some further intervention.
Correct.
And there could be certain circumstances in which the level of alertness did not require additional medical interventions. True?
That's true.
Okay.
Okay, that's all I have. Thank you.